Thank you very much. This is a little bit long lecture, so I included some cases here, so maybe I can skip my case presentation and take the time of the case presentation for this, to incorporate the case in this lecture. So I think when we evaluate the indication for cabbage versus PCI, I think we have to look at many steps. Variable related to the patient, variable related to the lesions, variable related to the device we have and the procedure we plan to do, variable related to medical therapy that this patient can take, complete versus incomplete revascularization that we can achieve, and variable related to the operator. So the final decision is not just looking at the lesion. You have to look at many spots to make the very final decision. Not to forget about the operator, because if the operator does not have a lot of experience, the decision is different. I will skip hybrid because it's another field. Variable related to the patient. Diabetes in general will favor cabbage. The result of freedom trial remain a benchmark. Nevertheless, diabetes should not be considered a binary variable. Renal failure, for example, is not very favorable for surgery, so may favor PCI. Low EF, neutral or site and operator dependent. Very low EF may favor PCI with support device. Impeller, now we have limited role for balloon pump. So if you have a patient who is diabetic and has very low ejection fraction and renal failure, maybe you go for PCI and not for bypass, even if diabetes calls for bypass. If you have an 83-year-old gentleman who has diabetes, you go for PCI. I wish I had diabetes at the age of 83 years old. That's a gift to be diabetic at 83 years old. So I think there are many variables besides. This is a very recent paper, Impact of Diabetes on the Outcome in relation to the coronary artery. A lot of patients, I don't know how much you trust in meta-analysis, but this was a big studies, and in general confirm what I just said. In diabetic, they do worse than non-diabetic. I think this is not such a dramatic information, was known even 10 years ago. Cardiac death and MI and TLR, again, no diabetic do worse. But look at this 87-year-old gentleman who has a diabetic, and he comes with this kind of anatomy. Would you send this gentleman for bypass surgery? I don't know. What do you think? Let's take even the LAD is not. It's a lot of disease. You have to put the mammary very distally. What do you suggest? But here is not so bad, and if you look here, it's not so bad. I think the surgeon can definitely put a mammary here. So here we did, of course, PCI. We did the rotablation on the LAD. This is after rotablation. And as a matter of fact, we did not do the left main because we did the FFR on the left main and was negative. And we have, let me go back. How do I go back here, like here? We did FFR on the left main at the end and was negative. And this patient came back for 4 years follow-up. This is a 4 years follow-up on this left main. And this is the same. So that's yeah, of course. Of course, if you do FFR and is not critical, and let me go back to the. This is the original lesion, and this is 4 years. So, and we didn't implant. We didn't implant any stent here. We just did balloon, drug-eluting balloon. We measure the LAD. But in this case, as long as the LAD is negative, it's fine. Of course, you may change your approach if this patient is 60 years old. It's a different story, but I emphasize the age because I believe that the diabetes should not be considered a single variable. Diabetes needs to be put in the context. If I have a patient who is diabetic and has a proximal LAD lesion, single lesion 3.5, I can place a stent with optimal result. I really don't care if he's diabetic. Myocardial viability, it's another open question. In the STITCH trial, patient with myocardial viability has significant better survival, but the assessment of myocardial viability did not identify patient with survival benefit from bypass as compared to medical therapy. We discussed yesterday this topic. I think this limitation is due to the fact that viability was not measured accurately. So I still believe that if you measure viability accurately, you may get an advantage. Variability testing was performed in 600 at discretion of the physician. The STIC trial, again, no advantages of viability. Look, without viability and with viability, more or less the same. Revascularization required if viability. Revascularization seems to improve outcome in presence of viability. This is a different study which comes to opposite conclusion. Revascularization, medical therapy, viability, look at the difference, no viability, no difference. So I think the question is still open because you can find studies proving the opposite. Variable related to the lesion. Anatomical complexities are Sinter score, number of stents, complexity are important, but need specific evaluation. Anatomical variables are not only pertinent to PCI, but also to bypass. If the vessel is bad quality, bypass is not a good idea. This LAD is not good for bypass. Look distal here, a lot of disease here. Usually the surgeon puts the mammary here. What's the point to place the mammary here? Of course, you can do endoatherectomy, but there are not many surgeons willing to do endoatherectomy. So even in a triple vessel disease, the condition of the anatomy affects the decision to do bypass surgery or not. Again, look at this LAD, how small diffuse disease, not ideal for bypass surgery. Left main, Excel established PCI non-inferior to Cabbage, noble, still questionable results, but I think left main should not be considered yes, no. This is a bad left main, not because of the left main, but because there is an occlusion of the LAD. This is complex. If the LAD is good, this goes to bypass. This is a very relatively simple left main, 1 stent crossover, no disease on the circumflex. This is another one, a simple stent, 1 stent crossover. So I think to call left main as a single disease is not totally correct. In addition, sometimes left main interventions are frequently more dependent upon lesions outside the left main. The left main is the easiest vessel to treat. It's right there. Sometimes is more complicated than the other arteries. Look at this patient. This patient has left main disease, but the left main is not an issue. The issue is the occlusion of the LAD, diffuse disease of the circumflex, occlusion of the right with the only disease in the acute marginal. Proximal LAD, PROTECT trial, DES implanted on the LAD versus outside the LAD. At 4-year follow-up, the incidence of myocardial infarction was 6.2% in the proximal LAD versus 4.9% for stent implanted outside the proximal LAD. So the proximal LAD protects the proximal LAD, but not the distal LAD. The difference is not dramatic, but whatever, there is a small difference. The intermediate LAD lesion remain a weak segment. That's the reason why people say mammary protects the LAD, because bypasses the intermediate lesion. Intermediate is from the ostium to distal. 20 years ago, Rick Kunz proposed to routinely stent the LAD from the ostium to the mid. This was a funny idea, did not work, but it's important to say. Variable related to the device. IVUS and FFR, new generation DS. If you have these devices, maybe you can tackle more complex lesions. IVUS is important not just to look at the lesion, but to do something. Look at this relatively small vessel, distal circumflex, after stent implantation, after first optimization, after second optimization, you go from an area of 3.45 to an area of 4.65. Big difference. High pressure inflation is fine here. Why don't you stop here? Here you have a diameter of 3.9, here is 4.6. It's not a big difference numerically, but from 3 to 4.6 is more than 20 to 30%. So it's for this small vessel is a big advantage. And I'm sure that without IVUS you would have stopped here with this cross-sectional area. So I say that IVUS does not work by intention to treat. There is not a convincing randomized study, but there are many registries. This is a big registry from Korea. They say that IVUS guided improves mortality. Still not totally convincing, but these are the best data we have. We have this meta-analysis of IVUS versus angio, where you see that there is an advantage in death, there is an advantage in MACE, and in TVR everything is is with a p-value. But again, these are meta-analyses. FFR, I think, is important also not to do some intervention. Whoever gonna believe that this lesion is not critical, I think there is a mistake here, I don't know. But if you show this lesion to a surgeon, he will have no mercy to consider this lesion critical. But I tell you, we really did FFR with adenosine very carefully, and the FFR was 0.90. So I think sometimes FFR is going to change our field. So variable related to medical therapy. Can the patient take a DAPT for how long? Number needed to treat versus number needed to arm. Consider the bleeding. The need to consider no polymer death, bare metal stent, or I think bare metal stent are out, or bypass. So I think these will affect your decision. I think we skip this complex diagram. One of the last issues is complete versus incomplete revascularization. CABG always demands for complete revascularization. PCI, you don't necessarily need to do complete revascularization in the same setting. You can do it even next month or even next year. Look at the left main I showed you. After 4 years, you can still do PCI on the left main. And in addition, there is this terminology of reasonable incomplete revascularization. You treat the LAD and maybe you just do nothing on this obtuse margin. What's such a big deal if you leave the patient with a stenosis here, if these stenosis are stable? This patient will be randomized in the ischemia trial even without doing nothing. So I think leaving some additional stenosis in small branches is not a big deal. Variable related to the operator, finally. This is a very old slide from the syntax trial, and here tells you the MACE according to the centers. Look, if you go here in this hospital where they have a MACE rate of 45% when you do CABG, not ideal place. I prefer to have CABG here where they have a MACE rate of less than 10%. But if I have to do PCI, I prefer to go in a place where the MACE rate is very low, like here, not in a place like this or like this. So I believe we have to take into account these big variabilities that we never really take very seriously, but there is in the real world big variability. So in the last decade, many things have changed. We have second generation, third generation DES. We have seen the appearance of very thin struts DES. We have learned appropriate selection of the lesion to treat. We are accepting what is stent optimization. We have high CTO success, and we have better antiplatelet therapy. All of these are something that are coming after the syntax trial. And I just want to finish to say something about syntax 2. Syntax 2 was a registry, unfortunately, was not a randomized trial, but is a prospective single-arm open registry, triple vessel disease, very similar to syntax 1. Inclusion criteria was more or less the same, 450 patients enrolled. The primary endpoint was 2 years MACE as syntax 1, peri-procedural MI defined at 5 times CK or troponin over 35. So remember, this is post-procedural MI, and exploratory primary endpoint MACE versus CABG compared to syntax 1. And they did FFR, in almost all lesions, which is very important because made the operator not to treat a number of lesions. I almost done as soon. So lesion not assessed by FFR, only 25%. So not many lesions were not. I need. Doesn't go. Okay. Now go. So in addition, in this trial, look at the CTO success. CTO success in syntax 1 was 53%. In syntax 2, thanks to new technology, was 87%. Big difference. Use of IVUS in syntax 2, 84%. In syntax 1, 4.8%. I already showed these. So now come to the data, mortality. Syntax 1, 5.5 at 2 years, 2.7 syntax 2. This is not randomized, but very similar population. Remarkable difference, almost half. Myocardial infarction, 5.8, 2.1. Very few late stent thrombosis because they didn't use a Taxus stent. Definite stent thrombosis, 3%, 2.9 versus 0.9. A primary endpoint, including revascularization, 21%, 13%. This is contemporary PCI. And here, very provocative exploratory endpoint. This is bypass of syntax 2 in red and PCI in syntax 2 in blue. Look, they are almost the same. So maybe if we do better, the way we just described, we can be as good as bypass surgery. So I think I can finish here. Even here in the syntax core, but the message is to go back to various variables and to do PCI according to current standards and not to old standards. Thank you for your attention.